Chapter 3. Okay. What I'm going to go into is some of the basic mechanical features of the cardiac pump and some of the factors that influence and regulate cardiac output and things that estimate cardiac mechanical function. This is what I was talking about the last half an hour or so, is correlating the pressure volume curves to the actual cardiac cycle. What I want you to do is that these pressure volume curves actually give you a direct correlation in time. So what you look at here is this preload curve here is pointed right to here. Okay? Isovolumetric contraction is this, and the afterload point would be here. It correlates to this. This stroke volume that you're seeing here is this. Okay? And then your aortic valve closure point, make it blue, is here. Okay? And then it drops off. This is isovolumetric relaxation. That would be isovolumetric relaxation. And then this point would be mitral valve opening. Okay? Now what's important for you to understand is the book is wrong. The book states that that diastole starts at mitral valve opening. It does not. Diastole starts at aortic valve closure. And that's the right, correct terminology. When you're looking at pressure over volume curves, the diastolic phase occurs right here. From here this way is all diastole. And then from here this way is systole, which then correlates with this. Okay? So these are all things that you have to sort of begin to understand, hopefully. I'm not a stationary person. I have to walk around when I talk. It's kind of driving me crazy behind this thing. Okay? So the heart can be described by changes in pressure during cardiac cycle. The pressures vary depending on the location of measurement. That's one thing that's important. When you're looking at this pressure over volume curve here, this is a measurement of intraventricular pressures. In this case, we're looking at the left ventricle. So that's the only thing. If you were to make a pressure volume curve for the right atrium, it would look different than this. We don't ever use that because the atrium is really not that important in the sense of survival. If you lose the atrium, you'll still be just functioning just fine. Just you lose preload is where you lose it at. Okay? So when somebody goes into atrial fib and atrial flutter, you normally don't see any effect. You don't see them really that symptomatic. Now somebody who has a low cardiac output state and could have diastolic dysfunction, they could get into trouble pretty quickly if you lose atrial kick. Because in those situations, that person may be as much as 40% of their preload dependent on the atrial kick. But in normal circumstances, these pressure volume curves, which correlate more with the left ventricle, are usually the models that we use. Come on. Okay. The other thing you see is that the left and atrial pressure curves over time look exactly the same except for the changes in pressure. The left atrium pressures are higher than the right atrial pressures. And the reason for the difference is that there's differences in compliance of the ventricles that it's pumping into. The left ventricle is thicker and is less compliant. So as a consequence, the same amount of volume that's being displaced is going to generate a greater pressure for that change. So left atrial pressure monitoring, which is what we call PA occlusion pressure, is higher than your CVP, or your right atrial pressure monitoring. Although the waveforms look exactly the same, the valves are normal, so you still get an A, C, and V wave. If you look at your left and right ventricular pressure curves over time, they look, again, the same, except for differences in pressure. The pressures in the right only usually generate pressure about 25 systolic, and the diastolic pressure usually drops down to 5, versus the left ventricle has a pressure usually of 120, and the pressure usually drops down to 15. Okay, so the waveforms will look the same. You have to look at it very carefully. Don't get fooled in that. Look at what the pressures are saying on the side to denote if you're looking at the right side or the left ventricle. Okay? If you look at aortic and pulmonic pressure waveforms over time, they look, again, the same, except the pressure to heights. Okay? On the other hand, if you look at volumes themselves, you cannot tell the volumes from the left to the right being any different. The right atrium displaces the same amount of volume as the left atrium. The right ventricle and the left ventricle displace the same amount of volume over time. and as well as the aortic and pulmonic valves, they displace the same amount of volume as well over time. You can also get flow diagrams, which I'm not going to go into that just right now, and you can also do a combination of units as well, which is pressure over volume curves, which is what we use. The timing should be broken down into two components, diastole and systole. Diastole terminates when the aortic valve closure, which in other words, which I just described to you before, is this here. So everything after this is diastole. And then systole is when the mitral valve closes to this point here. Okay? So please don't make that mistake. The book says it wrong, so make sure that you don't answer it that way. Diastole is when the ventricle is able to relax. It begins with closure of the aortic and pulmonic valve. The middle of diastole is isovolumetric relaxation. This allows the ventricle to not change volume, but allows the muscles to relax because the mitral valve at that point is closed. Next thing that happens is if you're looking at the right ventricle, is the tricuspid valve opens. If you're looking at the left ventricle, the mitral valve opens, which then allows passive filling, which accounts for about 80% of the volume being filled into the ventricle is due to passive refilling. Then the atrial kicks kick in, which accounts for about 20%, which occurs at the end of diastole, and it plays an important part of increasing the volume. In some situations where the ventricle is failing or it's more stiff, atrial kick can become more important. The diastole ends when the mitral valve and tricuspid valve close. The left ventricle, this is the point of maximal volume in the ventricle, which we call the left ventricular end diastolic volume, okay, which correlates with the left ventricular end diastolic pressure. Systole begins when mitral valve closure and tricuspid valves close. The aortic pulmonic valves are also closed during this time period. Then it's followed in the middle by isovolumetric contraction, and eventually the aortic and pulmonic valves open, which allows ejection to take place. The ventricular ejection is with a rapid ejection is during the initial phase, followed by slower ejection at the end, which is in the peak systolic pressure that you're looking at there. At the end of systole is when the aortic and pulmonic valves close, and it leads to what's called the dichrotic notch. Now, the aortic and pulmonic valves do not close at the same time, okay, which means that when you're listening to the heart sounds, you can hear what's called a split S2. Okay, you hear two sounds for S2, because which one's going to close faster, you think? The aortic valve. The aortic valve is going to close faster because there's more afterload behind it. So the valve is going to close faster. Okay? Now, I can actually make the splitting go away by doing something to the patient. What can I ask the patient to do? Take a big deep breath and hold it. And when I do that, I basically increase my pulmonic vascular resistance, and then it goes from being a split S2 to being basically an S2 where you don't hear the difference. Okay? So then the pulmonic valve closes more rapidly. The right heart waveforms. The right side, when you're putting a PA catheter in, this is why you need to know this, because you're going to be putting in PA catheters in as part of your training. I'm trying to make sure that you guys know what you're looking at. You do not need to have an X-ray to figure out where you're at. You know by looking at your waveform exactly where you're at. Okay? So one of the things that when you put in your PA catheter, you put an introducer in the neck, usually, and then you pass your catheter in. When you pass your catheter into the superior vena cava, which is in the right atrium, basically, here's your catheter, you will see a waveform that generates that looks like this. Okay, that's your ACV, ACV. Now, of course, if you just measure it by looking at taking your measurement and going down to a really low amplitude, you'll see this, which is what a lot of you are accustomed to. I would recommend that you don't do that. Okay, do not have your pressures at 120. Make sure you have your pressures at 20 or 30, okay, so you can actually see the waveform. Because what will happen is when we talk about tricuspid valve dysfunction, tricuspid stenosis, you can pick up if there's any problems. Normally, the A wave and the V wave are the same height. That's what should be. Okay? So the C wave is in between them. The way you find the C wave is look for the QRS on your EKG. and the QRS will be right here every time. So that's your QRS. Sorry, Q. Okay. So your QRS is right where the C wave's at. What does the A wave stand for? A wave stands for atrial contraction. It's at the end of the diastolic period where the heart is now beginning to have the atrial kick. So A wave stands for atrial kick. Okay? C wave is cusp closure, which is consistent if you're looking at, in this case, the CVP, you're looking at the tricuspid valve closing. Okay? The tricuspid, when it closes, it bulges upwards like a parachute. Okay? As it bulges upwards, it generates a pressure wave as more blood is returning back to the right atrium, which is causing the C wave. Okay? As that bulge stops and tightens, then the C wave disappears. And the next thing will happen is as the atrium begins to accept more volume, it begins to dilate and accept more volume, but it generates a V wave. So V wave is due to atrial filling. Okay? But it usually occurs during the ventricular contraction phase, and that's why it's called a V wave. But it's due to filling up of the atrium completely. So at the top of the V wave is a point of maximal volume inside the atrium before it begins to open up. Okay? When the V wave begins to drop off, that's when what happens? What happens here? The tricuspid valve opens. So now you're allowing isovolumetric relaxation to take place. Okay? Make sense? So that's the section of where diastole begins. All right. Everything that happens between the C wave and the V wave, in other words, from here to here, okay, is occurring with the tricuspid valve normally closed. So at that point, when you're looking at this measurement, it tells you nothing about what's going inside the ventricle. Nothing. You don't know what's going on because there's no way of looking in the ventricle. The valve is closed to you. Okay? So the only thing that you care about, really, in normal circumstances, is right before the C wave to know how much volume is inside the ventricle. Before the C wave, the volume is still visible to you as a catheter. So you can see whatever that pressure is. Okay? When the valve closes, that forms a door between you and the visualization of the ventricle. So the maximum point of volume in the heart is right here, right before the C wave. Okay? Now, the next thing that's generated as you're putting in your PA catheter in, you will begin to push it in further. Usually you put the balloon up at around 20 centimeters, and you'll float the PA catheter in. When the PA catheter is floated in, it'll get into the ventricle. So you'll be inside here. What that generates is a different kind of waveform. So you go from your CVP waveform, A, C, V, A, C, V. All of a sudden you do this. Okay? And the pressure here is only to 20 to 25. Okay? This is the atrial kick, and this is the actual ventricular waveform. Okay? Now you know you're in the ventricle because there's no dichrotic notch, period, none. There's no valve that gets in the way. Okay? As you start getting into the outflow tract, okay? I'm not going to go into that. As you get into the outflow tract, you eventually will pass through the pulmonic valve into the pulmonary artery. As soon as you get into the pulmonary artery, you get what's called a step up. The reason you're getting a step up is because the pulmonic valve is going to close at a certain pressure. Okay, so you're going to get this change rapidly like this, and you're going to get a dichrotic notch, and then you'll see it stay like this. Okay? So it's a step up is due to the valve that's there, and the actual, of course, elastic component of the pulmonic vessel, which keeps the diastolic pressure from going to zero. Okay? Now that step up is a measurement of PA. That means that now the catheter is in the pulmonary artery. Okay? Does that make sense? That's all describing the right side of the heart. So when we talk about CVP, is the right atrial pressure, right ventricular pressure, and PA pressures are all descriptions of what the right ventricle is doing. Okay? All right, next. So what's the difference between the left and the right? Well, one of the things that we want to monitor is we want to monitor the left more because it tends to give you a much more accurate measurement of volume changes because the ventricle is much stiffer. So as the volume changes in the left, you see a rapid change in pressure with it. So PA occlusion pressure is usually a better monitor than CDP. Okay? Now, in the old days, we used to take catheters. I'm going to draw it in red. Okay? This is your pulmonary vein. Okay? And then your left atrium. And you have your mitral valve. And you have your left ventricle. And you have your aorta here. Okay? Now, what's interesting about this is in the old days, we used to be able to put a catheter in here during open hearts, and then we left them in there. And then when we finished using them, we pulled it, and we hoped to God that it closed. A lot of times, of course, it didn't. So we had to go back to surgery and fix the holes, which was never fun. Okay? So really, that didn't really work very well. Okay? So then somebody said, well, why don't we do what the cardiologists are doing? The cardiologists are doing this crazy technique where they're taking a catheter, and they're without a balloon. They would take the catheter, and under X-ray, they would actually see where the catheter was going, and then they would wedge it into a capillary. Okay, they would wedge it into a pulmonary capillary. So what they were doing essentially, they were taking the pulmonary vein and then going to a capillary bed. And they were taking the catheter and embedding it right inside here. And all the forward flow stopped, and they would get the reflectance wave coming back from this. Okay? You can imagine how dangerous that is. Wedging a catheter is not safe because you're taking a small little capillary and you're putting a plastic tube into it, and you can tear it really easily. And what will happen is then the person hemorrhages into their lung and they get a pulmonary artery rupture. Not a good thing. Okay? So most of us, especially when you're heparinized, you're going like, that's really not a good idea. Let's not do that. Okay? Some people tried and it really failed miserably. So instead, they came around with this guy named Swan and Gans. These guys were brilliant. The guy was sitting in Chesapeake Bay watching the sailboats go by. And he said to himself, well, why don't we produce something with a sail? We can float it in based on flow. Okay, we can actually direct the catheter. We don't have to use the X-ray machine anymore. We can actually let the catheter go where flow is going. Okay? Well, they tried the sail technique. That failed miserably. Okay, every time that the tethers were there, they would get full of clot. Bad things tended to happen. Okay? So that failed very quickly. So instead, they came up with a new thing. They designed a balloon. Okay? And the balloon is actually pretty special. It's not a normal balloon. Okay, if you look at a PA catheter next time, look at how it looks. Okay? It's not, normally a balloon looks like this. Right? Imagine you put a balloon in somebody, the flow would go around it, and it wouldn't push it, nothing would happen. It would just go around it. Okay? But instead, they produced a catheter with a balloon that goes up like this. It goes up as a square. And the tip over here is where the monitoring is at the end of it. Okay? Actually, if you look at the anatomy of it, when you put the balloon up, the tip is covered by the balloon. It prevents you from hurting the artery. So the balloon protects the tip. Okay? But understand that it's a square in the back. So it acts just like a sail. So catheters, PA catheters, are flow dependent. They're not gravity dependent. They're not directed. They're totally flow dependent. Okay? That's why when you look at a PA catheter in a chest X-ray, where does it found 99% of the time? Right side of the lung. Why? Because it gets 60% of the cardiac output. 40% goes to the left, 60% goes to the right. So it's more flow going this side. So as a consequence, you should expect the PA catheter should be always on this side, and it is. If you see the PA catheter on this side, what does that mean? That means flow is dropped off on this side for some reason. Pneumonia, PE, things like that will shift the catheter to the opposite side. Okay? All right. Now what are you doing? When you're taking the PA catheter, what the PA occlusion pressure does is that when you float it in, it wedges in it doesn't wedge, it occludes the artery, And now the capillary is over here, beyond it. Here's your little capillaries beyond it. So you're not wedging. So if you're using the word capillary wedge pressure, you have to stop using that. You are not a cardiologist. You're not putting in a catheter in the wedge position. And if you are, you're basically going to kill somebody. Okay? Instead, what we actually do is a PA occlusion pressure. PAOP is what we should designate as our measurement. Okay? Now, when you put your PA occlusion pressure up, what you're basically doing is you're converting that artery on that side into a vein. You're basically looking at the vein. Okay, so it's like putting a catheter in the left atrium. Okay, so when I talk about a PA occlusion pressure, basically it's a left atrial pressure monitor, period. Okay, that being said, that means that it can measure using the same waveforms. You can generate an A, C, and a V, and you do. The waveforms are the same. Sorry. And right here is where my preload is going to be. Does that make sense? Did I lose anybody? If you look at your, what I don't have this is in your graph, but I decided to just let you look at it from a different perspective. This is what I teach in the DNAP, and I'm going to have to upgrade my slides now for the masters to make it a little bit easier for you guys to understand. If you look at the PA occlusion pressure, this is what you would generate, the A, C, and V wave. Okay? And what I've added for you here is the differences between the compliance curves of the left ventricle is in the red up here. Oops, sorry. In the red up here. And then you have the blue, which is a compliance curve for the right ventricle. For the same amount of volume, you can see that the correlation is very different in the left side in comparison to the right. Okay? Even though the right and the left atrium have the same amount of volume, which they have to, okay, the pressures are different. Okay? That's why CVP is 5, and the PA occlusion pressure is around 10 to 15. That pressure difference is an indication to you that the ventricle is different in one side compared to the other. Now, sometimes you'll encounter some situations where the first PA occlusion pressure that you get is actually 25. Okay? And you may think, oh man, that's not good. The person's in volume overload, and I got to get them more fluid off them. But in reality, that individual could be hypertrophied. That individual could have a large, thick left ventricle, and this waveform now is shifted upwards like this. So that individual has the same amount of volume in the left atrium like they should be, but they just have a very high PA occlusion pressure. And that person needs that. If you drop their volume at all, you're going to put them in arrest, okay? Because that person is actually requiring high pressures to fill that same volume. And that's what's kind of tricky. This is what has not been taught well with PA catheters. And a lot of clinicians don't understand this. And as a consequence, they treat things based on numbers. You always have to treat based on the situation you're in. You have to look at correlations with echoes. If you look at your echo and you see that the person has ventricular hypertrophy and you see a PA occlusion pressure of 25, well, guess what? That's where they live. That's where you want to keep them at. So when you come off bypass, you don't go to 15. If you go to 15 of pressure, you're going to have no volume in the ventricle, and you're going to look at yourself like, man, I can't get the heart to pump. Well, because it's got no preload. Okay? So always correlate it to what your situation is initially with your echo to then make the determination if the ventricle is hypertrophied or not. Okay? Now, what's also helpful is that this PA occlusion pressure, when you actually put the catheter in deeper, into the left ventricle, you generate this waveform. You generate the same waveform as you do in the right ventricle, except the difference is now the height of the pressure wave. The pressure wave now generates it up in the 120 range, 125 range if that's normal. And as a consequence, you will see this kind of nice waveform that's easy to see. It's a left ventricle. The right ventricle would basically generate the same waveform, except the pressures would be only in the 20s. Okay? And then the next waveform that lives on top of this is, of course, your aortic pressure waveform, which is this. The aortic pressure waveform lives on top of the ventricular waveform. Okay? Under normal circumstances, the valve is completely normal, the aortic valve is normal. The ventricular wave basically mimics the aortic pulse wave. Okay? That it completely looks the same, except after the dichrotic notch. The dichrotic notch is, of course, due to the aortic compliance, so it's completely different. Okay, so I'll leave that at that. Go back to the other lecture. So when you're looking at your left ventricular waveforms and your aortic waveforms, your volume over time is the same in comparison to the left and right, as well as in the aortic waveform in the pulmonary artery and the aortic volume over time is the same. The pressure over time are very similar. The difference is the pressure heights. Now, in addition, besides generating pressure, your heart, when it moves fluid through it, it generates sound. Okay? And you have to be able to recognize different kinds of murmurs, so you're clinically able to pick up on diastolic murmurs and systolic murmurs. The first one that you have to look for is S1, which is the beginning of systole. That's when the valves, mitral valve and tricuspid valve, close. And you hear a click. Also you hear at the same time, almost at S1, is you'll hear the aortic valve and the pulmonic valve open. These isovolumetric contractions very, very fast. Okay? Usually it's best heard at the apex of the heart and occurs immediately after the QRS complex and EKG. This is followed by S2, which is the aortic valve closure, and you can get what's called the physiologic splitting, which is due to the pulmonic valve closing slightly later time than the aortic valve due to the differences in pressures and resistances. If you have spontaneous inspiration, can cause splitting to be more pronounced. In other words, the bigger the deeper breath, the less vascular resistance you have, so the better that individual, unless you do a Valsalva, which then you can reverse that splitting S2. And the S3 is not normally heard. You should not hear an S3. You know, it's lub dub dub. You should not hear that. If you hear that, that's consistent with congestive heart failure. The most common pathognomic sign of congestive heart failure is a ventricular gallop rhythm, which is an S3. And S4 is not normally heard. It's immediately after S1, and atrial contraction, rapid atrial filling of the ventricles is associated with that. So somebody who has diastolic dysfunction, you'll tend to hear an S4. That's pretty hard to hear unless you have really good ears, and I'm not one of those. If you look at pressure over volume curves, okay, diastole is isovolumetric relaxation, diastolic filling, and occurs with closure of the mitral and tricuspid valves. Systole occurs with isovolumetric contractions when the mitral and tricuspid valves are closed, and then the aortic valve opens, ejection, and the aortic pulmonic valve closure is the end of systole and the beginning of diastole. In the diagram, basically with pressure over time curves we talked about already, you can pick up preload, afterload, and contractility. If you look at tension over muscle length curves, it can give you things like in diastole, isovolumetric relaxation, passive stretch. In systole, it gives you isometric tension development and shortening. And the diagram basically can determine end diastolic length as well. So this is your pressure over volume curve. What I expect you to do for the test is, like I said before, is that you have to know each one of these locations, know where volume is at, which one's pressure axis, know where preload point is, where the afterload point is, know the contractility point, know the effects of systole and diastole, where they begin and end, okay? And know isovolumetric filling as well as contraction or relaxation. Cardiac output is a simple equation. Heart rate times stroke volume. And a lot of that is, it's simple, but it's not that simple because heart rate is affected by, of course, automaticity due to sympathetic and parasympathetic activation, so that has different factors. Stroke volume can be affected by three things. Okay, contractility, afterload, and preload. All those can affect stroke volume. Okay? If you know that your preload is not changing, okay, then usually, or afterload is fixed, then contractility can be easily measured and changes by seeing the changes in stroke volume. But most of the time, unfortunately, when we talk about these kind of things, these factors usually change one or two at a time, not just one at a time. They usually do two or more at a time. What I want you to really understand about this is when we start talking about this on a test, I only want you to change one variable at a time. So it's a little bit different than physiologically occurring, but you need to understand what happens when you just change one variable. Okay? If I normally increase preload, what should happen to my stroke volume? It goes up until I hit the failure point. And once I hit the failure point, then stroke volume drops off. If I increase afterload, what should happen to stroke volume? It should decrease. Okay? And if I decrease afterload, it should increase. If I increase contractility, stroke volume should increase. If I decrease contractility, stroke volume should decrease. So those are the kind of things that you need to know and understand. Now, determinants of central nervous system, the heart rate is central nervous system, is your sympathetics and parasympathetics. Okay, you can do parasympathetics activate the beta agonist, and the antagonists are acetylcholine receptors. You have the cholinergic agonist and antagonist, and then you have drugs that can affect heart rate. So many different things can affect heart rate. If you look at stroke volume, again, what I was talking about before, preload, afterload, and contractility. Preload has to follow Starling's law, and as you increase preload, does not lead to increased preload usually increases your stroke volume unless you go into the failure portion of the curve. If you look at also afterload, if you increase the afterload, you will decrease stroke volume, and you lose energy to open up the valves. And the greater amount of energy lost to that, the less ability it has to have a forward stroke volume. On the other hand, if you decrease afterload, you tend to increase stroke volume. So as you can imagine, this I've actually repeated this twice, so that's going to be a test question, as you can imagine. Okay. Determinants of cardiac output are heart rate, or the autonomic nervous system, both the parasympathetic and sympathetic. The sympathetic binds, the norepinephrine binds to beta 1, which then causes the heart rate to increase, and leads to cyclic AMP activation, okay, which is it's a G-coupled protein, which then ultimately increases calcium release, which then causes an increase in heart rate, an increase in chronotropy, which is the heart rate increases. It also causes an increase in action potential conduction, which is dromotropy. It also has a positive inotrope, which increases contractility, and also increases the rate of cardiac relaxation, so it's a lusotrope as well. Okay. If you look at your stroke volume, what changes it are preload, afterload, and contractility. And what I want you to sort of make sure that you understand is that cardiac output tends to increase as preload goes up, and decreases normally as preload goes down. And contractility has a certain changes as well to it, which we already talked about. I think this is kind of a nice graph representation that you can keep pretty easily in your head as to what affects cardiac output, simplified into heart rate. Sympathetics versus parasympathetics. Parasympathetics are in red because they slow down the heart rate, and in green is an increase in sympathetics. Now, if you look at the sympathetic activity, it usually will increase contractility, and usually will also increase preload as it vasoconstricts somebody. The downside to it is it increases afterload, which is a negative effect, because that actually inhibits forward stroke volume. So you can see that afterload is in red. Okay. So the two things that actually decrease cardiac output are increases in afterload and decreases in heart rate. That's under normal circumstances. The cardiac energetics, which is the next discussion, is how does the heart, where does it work mostly at? And the answer is during isovolumetric contraction. That's where about 80% of its actual energy is needed to be consumed. So that's a very high utilization. It requires a lot of ATP during that period of time. And if you looked at carbohydrates, it actually is very little of the actual total utilization by the heart. The heart only uses about 10 to 40% of its energy from carbohydrates. Most of its workload, its energy is provided by fatty acids. So people that were on diets, that were only on sugar, it was back in the 80s, people decided that, well, you know, proteins are bad and so is fats, so we're going to go into only sugar diets. Well, that was really bad. What ended up happening was the heart, we started to get people with cardiomyopathies of their heart because all they were eating was carbohydrates and their energy utilization was poor for the heart, and the heart began to basically dilate because it lost muscle mass. So you don't want to do that. Fatty acids are very important for muscle of the heart. ATP is ultimately the main energy packet for the heart. It's metabolized from glucose and pyruvate, and mostly metabolizes it from free fatty acids, triglycerides, and ketones, and then eventually forms it into the Krebs cycle. The acetyl-CoA is an important part of the end product of these processes, which then goes into the Krebs cycle, and the end byproduct of that is ATP, CO2, and water. Okay, so ATP is of course what you want. CO2 is a waste product, and water, of course, can be used in cells in other places. But CO2 eventually has to be extracted out. And the heart is, because it's using so much metabolism like this, is that it produces a lot of CO2. The heart cannot go anaerobic, so it doesn't. It structurally has a higher number of mitochondria and a higher concentration of myoglobin inside of it as well, and has a higher affinity for oxygen as well. The theory behind all this stuff is why it's important, because if you can induce a state in the heart to protect it by being able to generate more stores or to utilize less ATP, it's one of the things that we're considering doing. We can actually cause these pathways to be inhibited or activated by different kinds of drugs, which are in the process of being studied right now. And hopefully that'll help protect the heart from hypoxic events. If you look at determinants of myocardial oxygen consumption, by far the most important one is ATP consumption, which is 25% usage to basal metabolic rate. And the other thing that consumes most of it is contraction. So contraction is still by far the most important part of where ATP is utilized. Okay? And of which the 75% of that, okay, 50% of the total is used in isovolumetric contraction. So you have to say which one is being the area where the heart uses the most energy. The answer is isovolumetric contraction phase. And during that phase, there's really no external work being done, and it's ultimately determined by the cardiac output. Cardiac afterload. This should be shifted over. I'm not sure why this didn't shift over. Shift these two over. And these three. And it's also determined based on wall stress. The greater isovolumetric contraction force you have to generate, the more wall stress you have to generate. Okay? So reducing preload will result in a decrease in oxygen consumption. That's true, but also will limit your stroke volume, which also can be a problem. So it's not really the best way to do it. What we actually have done in the last few years to try to reduce cardiac workload for somebody who has already a high risk for developing ischemia is invariably they put people on ACE inhibitors. Okay? ACE inhibitors are afterload reducers. Okay? And by reducing afterload, you're reducing isovolumetric contraction time. Okay? So that individual uses less oxygen consumption as a consequence. Stroke work is actually the area in the curve, okay, which is, I'll show you this in a minute. It's increased by increasing stroke volume, increases in afterload, and most costly in ATP usage. So what I mean by stroke work is that when you're doing your pressure volume curve, generate this curve, the area inside here is the stroke work. Anything that makes the area bigger will make the workload go up. But which one makes it worse? The worst one of these workload-wise is the increased afterload. That's going to make the workload increase the most dramatically. Ultimately, the workload has to be delivered by adequate amounts of ATP. Otherwise, the muscle becomes depleted of it, and it becomes a problem. Now, the measurements of cardiac output, I'm not going to spend a lot of time on this because it's a little bit, I don't have enough time to cover all this, is that cardiac output can be done by the Fick method, which is a calculation method, dye dilution, which is what was done a long time ago, and still done in cath labs to this day, or thermal dilution, which is what we do this day. What thermal dilution does is basically we usually give a cold solution into the chamber that we want to measure, and the higher the cardiac output, the less time there is for the thing to cool, so the smaller the curve. Versus the lower the cardiac output, the more time that cold fluid is able to cause the blood to cool, so you actually generate a greater curve. So when you're looking at a dye dilution test, if you're looking at a thermal dilution test, if you see a large waveform, that usually indicates a low cardiac output state, not something you want to see. Okay? You can also do what's called cardiac contractility estimates. These can be done by imaging. By far, echo is really by far the most sensitive that I use every day. When I work in the heart area, we use the TEEs. Cardiac angiograms are also pretty helpful, as well as nucleotide ventriculography. What you're looking at is you're trying to figure out ejection fraction, which is how much stroke volume over your end diastolic volume is left. That's what EF stands for. The normal range is about 55 to 80%. And normal people are usually 60 to 70. And one of the things that also you can look at is your end systolic pressure-volume relationships, which as the volume empties more effectively, which is you get a greater stroke volume, then your systolic volume is less inside the ventricle. Okay. What that means is the following. Here's your pressure-volume curve. Okay. If that person ejects better, stroke volume-wise, they're able to eject over here. So their actual end systolic pressure, so then of course left ventricular end systolic volume is less, and also their left ventricular end systolic pressure is also less. Okay. That's what they're trying to tell you. Okay. The better the stroke volume, there's more emptying of the heart, usually. Okay. That's what the book's trying to say. Although we don't measure it that often, but sometimes they'll ask that in a C exam or something like that. Okay, gotta keep moving along. EKGs, next thing. When you look at EKGs, you got to figure out what you're looking at in the sense that you're looking at from the different chambers. P wave and the PR interval is basically describing everything that's going on in the atrium and the AV node. Then you have your QRS, which is describing what is occurring in the ventricle in the sense of his Purkinje fibers and the bundles. Okay? And then you have your T waves, which is repolarization that's taking place. So you can break it up into different components. Okay? The PR interval is due to the AV conduction delay. There should be anywhere between 120 to 200 milliseconds as a normal delay period. And that gives you the ability for the atrium to contract fully. Without that, then you would get too rapid of ventricular depolarization, and then the ventricle would not fill adequately. The QRS usually should be small in distance. It should be 60 to 100 milliseconds in diameter. It leads to ventricular contraction ultimately, but remember, this is electrical. Does not necessarily always tell you that the ventricular contraction is taking place. This is what leads to ventricular contraction to take place, but sometimes that will not take place in certain disease processes. The ST segments will tell you if the person is either ischemic or developing infarct. And then you have your T wave can indicate to you hyper or hypokalemia, which is part of the repolarization process. Contraction is very different than electrical activity. You can still have normal electrical activity and still have no cardiac induction, cardiac contraction taking place. This is again your normal QRS. Now this is what everybody thinks of, okay, as a normal EKG. This is lead 2 only. Okay, so please don't look at it. It'd be like looking at an elephant, and the only way you look at an elephant is looking at it from the side. Okay? And in reality, an elephant, you can look at it from many different views. You can have a three-dimensional view of an elephant. Okay? You can look at it from behind, his other side, look at him head on, and you'd see very different things. Okay? An EKG basically gives you a three-dimensional view of the heart. And as a consequence, even though we think this is a normal EKG, if you give this to a layman, everybody would tell you that's an EKG. I could take somebody off the street and show them this, and they'd go, oh yeah, I've seen that on TV, that's an EKG. But in reality, if I gave them a different waveform than this, they would have no idea what the heck I was looking at. Okay, if I showed them, let's say, lead V1 or V2, they would go like, I don't know what that is. But it's still the same thing. It's an electrical activity of the heart under the same phase. Now the current around the heart during the cardiac cycle moves from the atrium, which is the the P wave, which then causes the atrial contraction. Then you get the delay, which is due to the AV node. And eventually you get the his Purkinje fibers that then cause ventricular contraction. Now when you look at the EKGs, you've got to start by going back to the basics. If you haven't learned EKGs, you have to learn at least some of the basics here, and then study on your own because there's not enough time to cover all this. What I want you to be able to look at is that you're looking at two planes. The first one we look at is the frontal plane, which is this plane. It's a two-dimensional plane. Okay, and that's your leads 1, 2, 3, AVF, AVR, and AVL. Okay? The other plane, which rotates the axis from this to this way, which cuts your body in half, is the V1 leads. The V1 leads cut you this way. Okay, so you're looking at the horizontal way of your chest. The way I want you to think about this is that the leads always point towards the positive. Okay? Always the leads, when you put them on, they point to the positive. So if I look at lead 1, okay, which is we have the white lead over here. Okay, this is white, and then it goes to the black. Okay? Okay, the arrow that's generated is always pointing to the positive. Okay? Lead 2 looks from the red lead, from white to the red lead this way, which is lead 2. That's a positive. And then lead 3 is from the black lead to the red, which leads to lead 3. Now, why is that important for you to understand? Well, this is called Einthoven's triangle. Nobody remembers this because nobody uses this. Instead, we use a Cartesian plane, which I'll show you next. But what I want you to understand is that whichever way you put your leads at, okay, it will point the arrow to what you're looking at. In other words, where I put my finger painting it, that's what I can see. That's all I can see. Okay? In other words, if I put my white lead here, okay, and then I put my red lead here, okay, and that's lead 2. But if I take this same lead and move it up to here, I'm actually measuring V5. Okay? And you don't know that unless you move it around. Okay? So it depends on your position of your leads. Just because you got a red lead doesn't mean that the lead is actually looking at lead 2. You have to put it in the correct position to get the reading that you want. Now, the reason we use lead 2 so often, and that's why it's become so what everybody knows, it, even a layman knows what lead 2 looks like, is because that's the one that you can pick up arrhythmias on. Okay, because it cuts through the heart right through the P wave, AV node, and the His-Purkinje fibers are going through. So it gives you the best view of those areas. Okay? But on the other hand, if I'm looking for ischemia of certain areas of the heart, lead 2 doesn't generally do a good job of picking up an ischemia. It doesn't. Okay? If I want to look at the left ventricle, at the lateral wall, I want to look at V5. Okay? Because I want to put the arrow through that. Wherever I want to put my arrow on, that's what I want to look at. Okay? What drives me crazy is that every single location, every single ICU that I've worked at, everybody puts leads on differently. It drives me nuts. And I ask them, where do you come up with this? That's the way we do it here. Okay, great. I'm glad you do it here this way. Okay? You don't have a clue what the hell you're measuring. Okay? So what are we actually trying to measure? What we're trying to do is we're trying to cut up, because you know what? If anybody could just put leads anywhere, then why does EKGs work? EKGs work because everybody puts the leads in the same place every time. If you don't, which had happened the other day, I actually had an inverted EKG. And somebody handed it to me and said, look, this is bad. I said, no. I flipped it upside down and said, look, it's perfect. They looked at me and what? I said, you put the leads all upside down, dude. Go back and do it again. And they said, well, I was just trying to trick you, Dr. Nolan. And he sort of laughed. It's like, no, I don't think you were trying to trick me. I said, I don't think you knew. So, but things like that can be picked up by looking at it, okay? That being said, you got to put the leads where they belong, okay? Now, what you eventually are trying to do is you're trying to eventually produce what's called a Cartesian plane, okay? Which is all the frontal leads, which is lead 1, 2, 3, AVF, AVL, and AVR, are doing all this Cartesian plane. So you can split up the heart into different parts. Okay? So let me show you how this works. Lead 1 is going this way. Okay? Lead 2 is going here. Lead 3 is this way. Lead AVF is going, I'm going to make the red ones augmented. This one's AVF. AVL is going over here. And AVR is going over here. The way I want you to think about it is take this drawing and plaster it onto your chest. Okay? And wherever my hand is going, it tells me which lead am I going. Am I going this way? That's lead 1. So the axis is going through my heart this way. Not going to be very effective in monitoring anything, really. Okay? If I want to look at lead 2, I'm down here, AVF, and this over here, which is lead 3. Now that's called the inferior portion of your heart. Okay, see this axis that I'm sort of pointing at? This axis down this portion of the heart is looking at the right ventricle. Okay? So it's a way of monitoring for RCA disease. If I have somebody with right coronary artery disease, which is a cath lab shows that the guy's got a 90% RCA in the left main, everything else is okay, then I'm going to monitor 2, 3, and AVF during the case. Because I'm looking for ischemia. I'm going to see ischemia where I'm pointing it. Okay? So that's my front leads. Okay? Now, the other thing that's useful about this is that you can point your hand at which way it's right. This is my right hand, goes to the right, and this is my left hand going to the left. Okay, that's my AVL and my AVR. Now, why I try to make you memorize this? And I actually simplified it because it becomes useless because people don't remember it in 6 months. So I'm going to make it simple for you. How many people have played Battleship? Okay, everybody's played Battleship. They go like, A1, and they find it on the screen where it's at. Okay? Well, we're going to play the same kind of game. And we're going to keep it real simple. Okay? We're going to look at only 2 leads. We're going to look at lead 1, and we're going to look at lead AVF. Okay? When you look at lead 1 under a normal circumstance, what we're talking about is we're talking about the QRS. Okay? That's what we're caring about. Because ischemia doesn't matter in the atrium, right? If you get ischemia in the atrium, what are you going to get? Atrial fib, atrial flutter, you're going to have something weird happen, okay? But you're not going to get into ischemia of the atrium. The atrium doesn't usually blow out. And what you see ischemia that's important is in the ventricle. So what we're talking about is when we're talking about axis deviation or things like that, or a bundle branch block change, we're looking at the QRS. Okay? So under normal circumstances, if you look at QRS on lead 1, it's positive. Okay? Depending on how big the QRS is, then the more positive it goes this way. I'm going to say this one is 1, 2, 3, 4, 5. It's 5 high. Okay, so it's going to go 1, 2, 3, 4, 5. Okay, so that's where it's at. Okay, that's in lead 1. But then I look at lead AVF. In my lead AVF, this individual has the following EKG. It looks like this. That's my AVF. And it's going 1, 2, 3, 4, 4. So it's going to go down AVF, 1, 2, 3, 4. Okay, now I'm going to walk across, okay, and then my new axis is here. So that person has an axis deviation of what we call plus 60. Okay, sorry, plus 60. Okay, going 0, 60. That's where the normal axis is at. Okay, that being said, now what happens? Why is this important? Well, here's what happens. If you're doing a case, and all of a sudden the axis shifts on you. Okay, let's say the patient has developed ischemia of the left ventricle. Okay, and when that person develops ischemia of the left ventricle, they go from a normal EKG pattern, they go into a left bundle branch block. Okay, and what a left bundle branch block does is it lets the electrical activity go to the right first, and then because the ventricle muscles eventually depolarize, it takes longer for the axis to shift. So the axis, when you did a left bundle branch block, is going to shift to the left. Okay, so your axis is going from here to here. So what would you see? When you look at your EKG in lead 1, you would see rabbit ears, but they'd still be positive. Okay, so they'd still be positive. But in lead AVF, your EKG would do this. So it becomes positive. Okay? Sorry, not positive. What the hell did I do? I flipped it on me. Damn it. Should be negative. Screwed up. This initial AVF should do this, positive. Okay, that should be AVF initially. And now when you went into the bundle branch block, your axis should switch. P wave. Negative in this direction, so it's negative 1, 2, 3, 4. So now this person goes 1, 2, 3, 4, negative. So the axis is over here. So that person rotates the axis to the left. Okay. If you do the same thing with a right bundle branch block, okay, it rotates more to the right. So what you'd get is a negative in lead 1, and you would be a positive in AVF. Okay, wherever your arrow is pointing, it's always positive. If it's going the other way, if it's deflecting downwards on your EKG, that's negative, and that goes in the reverse direction. Sorry about that. Okay? Does that make sense? Did I lose anybody? All right, we'll get back to it and make it more clear. Now, the other thing that the EKGs will lead is the other pattern you look at is you cut the chest. And now you're looking at the horizontal view. So now the arrows are going forwards. They're going in this direction. Okay? V1 is here. V2, V3, V4, V5, V6. Okay? So when you're looking at the arrows, you're looking at this way. Okay? Now, V1 and V2 will tell you, well, mostly V2, will tell you anterior lead, anterior ischemia. What's the anterior portion of the heart? LAD. LAD and left main. Left main will give you both, but LAD specifically for anterior. Lateral will be circumflex disease. Okay, and that would be V4, V5, V6. How many people knew this beforehand? Oh, okay. This is why we do this, okay? Let's say I walk into a pre-op evaluation of a patient. In the pre-op evaluation, the cath lab report comes back with the following disease process. The guy has, I'm going to draw the coronary arteries the way I see them. Left main, LAD, circumflex. Okay, LAD is D1, D2, OM1, OM2, circumflex, LAD. Okay, and then this one is RCA. Okay. This patient has the following disease process, let's say. We have 80% LAD, and we have nothing else, okay? So what I would do in that situation is I would take my EKGs and monitor for anterior wall ischemia. So I would look for V1 and V2. So I put my V1 and V2 lead on this guy and monitor for ST segment changes. Okay? If I have another guy with another disease process, let's say his LAD is normal in this guy, and instead we have circumflex disease of 80% here, okay? Then what I'm going to do is I'm going to monitor the lateral leads. So I'm going to monitor V4, V5, V6 for ischemia. And if I have RCA disease, I'm going to monitor inferior wall, which is lead 2, 3, and AVF. See, now it's practical. Now this stuff is becoming useful. Okay, it's not just, well, I'm just putting EKGs and sort of hoping for the best to pick up for ischemia. No, if you have additional information that tells you the anatomy that you've got a problem, you need to monitor that more carefully. Okay? I'm going to go past this because this does not help. So I've been skipping all this. Okay. What I want you to know is axis deviation. The normal axis is around 60, which is normal, around 59 to 60, so down this way. So right down here is normal in the green. And it goes anywhere between minus 30 to 105 is considered normal for most individuals. If you see a left axis deviation, most likely common cause, that's left bundle branch block. Okay, or left ventricular ischemia can also cause a left axis deviation, which is both worrisome. Okay? The other thing that can cause a left axis deviation would be left ventricular hypertrophy. Okay? Which is the thicker the muscle, it takes longer to fire. So you'll see the axis rotate to the left. Remember what you're looking at. This is a composite. This is a 12-lead EKG. This is still looking at the elephant, just looking at different views. Everybody's used to lead 2, because that's what we all use. Okay? If you're monitoring for any kind of arrhythmias, you must monitor lead 2. So lead 2 should always be on your machine when you're monitoring, period. Always. And that's why we have 5-lead systems. If we have 5-lead systems, then we monitor more than one. If without 5 leads, if we have only a 3-lead system, you can only measure 1. That's kind of bad. Okay, and then you got to pick which one do I monitor, ischemia or arrhythmia. Kind of a tough choice. Depending on how bad this person's at risk, I may go away from lead 2. Okay, but I usually will try to pick out a monitor that's a 5-lead in that patient because I want a more careful monitoring in that individual. Okay. The conditions that cause abnormal voltages in the QRS complex Things that increase the voltage will be hypertrophy. Decrease the voltage are things that will cause muscle wasting, or there's fluid between, or air between you and the heart, and the EKG in the skin. So if you have cardiomyopathies, that could cause decreased voltage. You can have cardiac tamponade, pleural effusion, COPD, or pneumothorax can all lead to a decrease in voltage. Prolonged and bizarre patterns of the QRS complex are usually from hypertrophy, dilation, the heart. You can have alterations in the Purkinje system, including the bundle branches, and you can also see it in cardiac injury patterns. Okay, then let's go on to chapter 5. Let's see if I can get caught up. I'm not going to get to it all, but I'm going to do some injury to this today. If you look at cardiac conduction problems, okay, what I expect you to know on this test? Well, you need to be able to pick up atrial fib, atrial flutter, ventricular tachycardia, VFib. Everything that you know in ACLS, I expect you to know. I'm going to give you a picture of it, and now I'm just going to ask you to identify it. Next semester, I'm going to ask you the same question, except I'm going to ask you what causes it. So for now, just have to identify it. Don't go crazy as to what causes it yet. These are the major causes that I need you to think of. Okay? So when anybody tells you that you see a cardiac dysrhythmia, you don't pull out the medications first. You come out first with thinking what is causing it. Okay? It is antiarrhythmics are not safe. They are dangerous drugs if you give it for the wrong reasons. So you need to identify what the major culprits are that are causing the arrhythmias. The number one culprit is hypoxemia. And so you must check your pulse oximeter, make sure that your FiO2 is okay, make sure you're not delivering carbon monoxide poisoning or something weird's going on. Okay? As long as you're not delivering those, then you should be fine for most arrhythmias. Okay? But hypoxemia is a real big culprit for seeing PVCs and any kind of ventricular arrhythmias like VTAC or VFib. Always think arterial hypoxemia in the back of your mind. The other thing to think about is electrolyte disturbances like potassium and magnesium. Both hypokalemia and hypomagnesemia may lead to atrial dysrhythmias, especially tachydysrhythmias. And so low potassium, low mag levels will tend to cause more atrial dysrhythmias. Hypomagnesemia can cause severe forms of VTAC, which is called Torsades points, which is what you want to avoid. Acid-base disturbances can also lead to dysrhythmias. Acidosis usually is the worst culprit. Altered activity of the autonomic nervous system. We see a lot of PVCs in pain. Usually take away the pain, also the autonomic nervous system shuts down. And the person stops having PVCs. Increase in myocardial stretch fibers, such as hypertension or intubation of the trachea, can also lead to arrhythmias. Myocardial ischemia. Where you can also get a significant electrolyte disturbances is from hyperventilation. I've seen this happen. You have a student who's new, and the most important thing for them at that point is to breathe as fast as they're breathing. And usually they're panting like dogs, so they think the patient needs that. Okay? So they hyperventilate the patient like crazy, and what happens to potassium when hyperventilate? It goes down, okay? And all of a sudden you go into a tachydysrhythmia. All of a sudden you got a person who is going into a normal sinus rhythm, all of a sudden it's going into a fib on you, okay? And all you have to do to stop this is stop hyperventilating, okay? Let the potassium come back up, and all of a sudden the atrial arrhythmia goes away and terminates. So these little things kind of be helpful to you, okay? Myocardial ischemia, of course, is related to arterial hypoxemia in the sense of perfusion related. Catecholamines can cause very significant problems in some kind of volatile anesthetics. Most of the time, most of volatiles increase heart rate, except for sevoflurane. Coexisting cardiac diseases can also cause problems with pre-excitation and prolonged QT interval syndromes. Okay, the action potential, of course, we talked about this before, about the pacemaker potential here at the phase 4. You can get the tachyarrhythmias from increases in phase 4 slope, versus you can get a decreased effect in bradycardias with parasympathetic activation, which is a vagal effect. I'm going to have to change this thing. It's driving me crazy. This is what we talked about before, so I'm not going to go into it in more detail. What increases your phase 4 slope is following. Anything that causes sympathetic discharge. So increasing hypoxemia in the adult will cause a sympathetic discharge. In the baby, it will do the reverse. It will cause bradycardia. It will cause a dive reflex. But in the adult, usually arterial hypoxemia causes a phase 4 slope increase, which then causes the tachycardia. Hypercarbia will also do this, catecholamines, sympathomimetic drugs, acute hypokalemia, which is usually from hyperventilation from fear, hyperthermia, hypertension. Anything that causes basically a stress response will make the phase 4. So you tend to get more tachydysrhythmias. What's the most common arrhythmia that you encounter in the operating room? Sinus tachycardia. Okay, sinus tachycardia is sympathetic overdischarge. Decreased slope is due to parasympathetic activation. It's due to vagal effects. Okay, you'll see the phase 4 slope decrease, and as a consequence, you get heart rate begins to fall. You can also get this from positive pressure ventilation, will also cause this excessively as well, and hyperkalemia can also cause this as well. Now, when you look at arrhythmias, I want you to sort of break it up into looking at first always heart rate, and that'll give you either tachy or Brady. What's more dangerous? Brady's. Brady's are much more dangerous most of the time. Because once you start slowing down heart rate, you affect cardiac output immediately. The next thing you want to look at is look at the waveforms and see if you have P waves. If you don't have P waves or it disappears, then you have an atrial dysrhythmia. If you have QRS changes, then you have ventricular dysrhythmia. What's lethal is ventricular dysrhythmias. Again, that's one that you have to be more concerned about. And you want to look at the ventricular rhythm as normal, or if you're getting early cardiac beats. In other words, are you getting perfusion or are you not getting perfusion with this? Okay. Cardiac conduction always looks at the SA node, AB node, his Purkinje system, and his different components, which we already talked about before. The other thing to consider is that you have reentrant arrhythmias as a problem. You can have what's called accessory fibers, like bundles of Kent, which are things that people are born with that have accessory pathways and causes what's called circus arrhythmias, which means that the arrhythmia is originated by reactivation of tissue that should be already inactivated, and then it causes the heart rate to speed up. Reentrant arrhythmias tend to be tachydysrhythmias, usually things like Wolff-Parkinson-White syndrome is an example of a reentrant arrhythmia. Treatment is correct the source. Number one, correct the source. Don't forget that. Figure out the problem. Second is antiarrhythmics. Third is electrocardioversion, which we'll talk about in coexisting. And then we'll talk about as well as cardiac pacemakers, either transthoracic or transvenous. We'll go into that a lot more detail in the coexisting disease process. Let's look at the actual differences in cardiac impulse problems. The first one I want you to think about is you need to break these stuff into first, second, or third degree blocks, or also sometimes in between called unifascicular blocks, which is a right bundle, left bundle branch blocks. And the reason that's important for you is when you're putting PA catheters, you've got to determine which one is a lethal one. They can cause problems when you're putting a PA catheter. In the first degree block, you see a PR interval that's widened. This is something you see very often when you put somebody in positive pressure ventilation. That increase in resistance will cause the right atrium to dilate, and it will actually slow the AV interval up. And is it something significant? The answer is no. What I would tell you is sometimes that you maybe make this go away just by decreasing your tidal volume just a little bit, maybe by 50 to 100 cc's, and all of a sudden it goes away. So it might be an indication that you're causing too much pulmonary artery pressure increases. The second one is a second degree block, is looking at the Mobitz 1. This is an AV conduction delay. This is a benign process where the actual acceptance into the upper disease of the AV node, and the signal is just not accepted into the AV node. It doesn't mean that the trigger mechanism is failing, but what ends up happening is you get the PR interval widens, and eventually stops and fails. And usually these people are totally asymptomatic. And then when you put these people to sleep, nothing bad happens. They don't go into worsening Wenke-Bach or Mobitz 1. Mobitz 2, on the other hand, it's not a game. Mobitz 2 you should never take to the operating room. This is malignant in the sense that when you put them to sleep, they usually go asystolic. That's usually pretty bad. Okay? So I don't recommend it. I had one patient that I did this. I learned the hard way. I knew that was not the right thing to do. I talked to the cardiologist. The cardiologist said, oh, the guy's been in second degree AV block for 30 years. He's been fine. We haven't put a pacemaker in. He's not going to be, just because you're doing anesthesia doesn't mean anything's going to happen to him. And I said, well, this guy's undergoing general anesthesia with positive pressure ventilation, so that shouldn't make a difference. And I'm going, well, it's not what my literature says. Well, being benign, being a younger person, believing somebody with a lot more experience, well, guess what? I failed that test. As soon as we put the intubation and intubated in positive pressure ventilation, that guy went from a heart rate of 42, 45 to a heart rate of 10. It got really exciting, really quick. It was my first pacemaker that I had to put in my career. My point is, don't put these people in the operating room without a pacemaker in first. I learned my hard lesson the first time as a resident, and the next time that happened to me was a few years ago as a cardiologist came up with the same kind of nonsense. I said, nope, I'm not doing this under any circumstances, not in your day, not a regional, not a general, not any other way. I'm not eating my green eggs and ham. Thank you very much. So I said, you're going to get the pacemaker in. So they put the pacemaker in, patient went fine, no problems. That's the way to do it. Okay, don't get fooled into this. Phase Mobus 2 is dangerous. Okay, it's infranodal, which means that the AV node, the trigger disease, the disease is in the trigger. So the lower portion of the AV node is disease. When you put positive pressure on ventilation on these individuals, they will basically go asystolic or go severely bradycardic. The next things are the unifascicular blocks, which is right and left bundle branch blocks. Right bundle branch blocks are not the serious ones. The right bundle branch block, when you put it in a PA catheter, nothing happens. If you look at them, you'll pick up on D1 that you'll see double rabbit's ears, and you also have a right axis deviation normally. This is your rabbit ears. The way I remember it is if you take V, which is V, and flip it over and make a rabbit out of him. Okay, now he's a rabbit. Okay, that's why he's got the double ears. Okay, so that's your right bundle branch block. Okay, versus in left bundle branch block, okay, the rabbit ears in the first letter are in the L, which then you open it up so it's in lead 1, is where you see it. So that's how I remember it. I use little things like that to help me remember which side is which. And you also will see with the left bundle branch block a left axis deviation. You'll see it rotate to the left. I can pick up on the axis. Okay. Now, why is it right bundle's not bad? No, it's not bad at all because when you put the PA catheter, you're going into the right ventricle, and the right's already out, nothing's going to happen. But on the other hand, if you put in a PA catheter in somebody who has a left bundle branch block, you have serious condition. Okay? Because the right bundle is totally dependent on getting the electricity down to the ventricles. And when you put the PA catheter in, it's going to touch the walls. And when you hit the wall, that right bundle can go out, and it shuts down. Okay? And then you got asystole. A little bit of problem. Okay? One of my students, I was putting in a PA catheter, had the patient at a left bundle branch block. We had external pacemakers on them. This is what you do. You always put external pacer leads on those individuals before you start. And I told her, I said, okay, go in real slow. And all she heard was go. And she fed it really fast, and sure enough, she hit the catheter wall, and bam, all of a sudden we had asystole. It was rather exciting. We got the patient back. What's the first thing you do? Pull the catheter back. Okay? Put the balloon down, put the catheter back. Please do that. If you do that, you take away the stimulus, and hopefully it'll come back. Okay? In this case, it didn't. We had to do chest compressions on it for a little bit, and then an external defibrillator fired up and get the pacemaker working. And eventually, the guy came back. It was rather exciting for about 3 minutes. Try not to do that. Third degree AV block is actually a very serious condition where the AV node is basically diseased. And the QRS now have no correlation at all with P wave, so it basically marches through. The condition is serious because usually the heart rate's usually slow, usually in the 30s, which is the intrinsic heart rate of the ventricle. The primary cause of this is primary fibrous degeneration of age. It can also, from ischemic heart disease, cardiomyopathies can also induce it. Myocarditis, ankylosing spondylitis, which is inflammation of the heart, can lead to this as well. You can also have it from iatrogenic causes from heart surgery, from congenital problems, and increased parasympathetic activity from deep visceral pain can cause complete third-degree AV block to take place. Drugs such as beta blockers can also induce this, and severe hyperkalemia can do complete third-degree AV block.